welcome to the June BeWise webinar. My name is Anna Testa, and I am the BeWise Clinical Service Coordinator. I will be giving you a presentation today about hypertension. The learning objectives for this presentation is to describe anatomy and physiology of the normal heart, compare and contrast primary or essential hypertension and secondary hypertension, discuss risk factors for primary hypertension, compare and contrast pre-hypertension, stage 1 hypertension, and stage 2 hypertension parameters according to the JNC7 guidelines, describe effects of uncontrolled hypertension on body organs and systems, describe lifestyle modification recommendations to control hypertension, describe benefits of self-measured blood pressure monitoring, demonstrate proper use of home blood pressure monitor, and briefly discuss the BeWise self-monitored blood pressure pilot project. Let's talk about some staggering statistics about hypertension. Heart disease and stroke caused by hypertension are the leading causes of death in the United States. 1 in 3 adults in the United States have hypertension, but only 1/2 of the people with hypertension have their blood pressure under control. Increased blood pressure was a primary or contributing cause of death for 1,000 people per day in 2013. And high blood pressure costs $46 billion every year. So to get a better idea about high blood pressure, let's take a look at the heart. The heart is made up of 4 chambers, the left and right atria, and the left and right ventricles. Deoxygenated blood returns to the right atria from the venous circulation in the body. It is then pumped into the right ventricle and through the pulmonary arteries into the lungs, where it exchanges carbon dioxide for oxygen. The oxygenated blood is returned to the heart's left atrium through the pulmonary veins and is pumped into the left ventricle. The left ventricle pumps the blood through the aorta and into the body's circulation. The pressure created in the arteries by the contraction of the left ventricle is the systolic blood pressure. The diastolic blood pressure is measured when the left ventricle is relaxed. Let's watch a short video to get a better look. Well, the video doesn't seem to be working. Let's see if we'll come back to the video. Hypertension occurs as the interior diameter of the blood vessels becomes constricted and the heart must pump harder to force the blood through the arteries. Imagine a garden hose that is kinked. The water must be pushed through at a much higher pressure to be able to come out of the hose. There are 4 categories for the classification of blood pressure. Normal blood pressure is a systolic blood pressure less than 120 and a diastolic blood pressure less than 80 millimeters of mercury. Prehypertension is a systolic blood pressure of between 120 and 139 or a diastolic blood pressure of 80 to 89. Stage 1 hypertension is a systolic blood pressure 140 to 159 or a diastolic blood pressure of 90 to 99. And stage 2 hypertension is a systolic blood pressure that is equal to or greater than 160 or a diastolic blood pressure of greater than or equal to 100. Primary or essential hypertension occurs 95% of the time and is characterized by the absence of an identifiable cause. Blood pressure tends to rise with age, and about 65% of Americans over 60 years old have hypertension. Hypertension is more common in African Americans than in Caucasian or Hispanic Americans. Women over the age of 55 are more likely than men to develop high blood pressure. Additionally, a family history of hypertension raises the risk of developing high blood pressure. Lifestyle habits that increase risk for hypertension include being overweight or obese, physical inactivity, use of tobacco products, eating too much sodium, drinking too much alcohol, and last but not least, stress. Secondary hypertension occurs approximately 5% of the time and is related to an underlying condition that can occur in relation to diseases that affect the heart, kidneys, endocrine system, or in people that have sleep apnea or who are pregnant. Various medications, such as pain relievers, birth control pills, antidepressants, and illicit substances can cause high blood pressure in some people. Because hypertension can go undiagnosed for so long, symptoms do not usually appear until the body is damaged from chronic hypertension. So what are the complications of persistent hypertension? There are changes in the brain that can lead to stroke, aneurysm, which is a bulge that forms in the artery wall that can rupture or block nearby blood flow, or cognitive changes such as memory loss or poor focus. In the eye, ruptured blood vessels can cause vision changes or blindness. Heart attacks or heart failure can happen. There may also be peripheral artery disease, which affects the blood flow to the legs. Aneurysms can also occur within the peripheral vascular system. Blood sugar can increase, and a narrowing of the vessels in the kidneys, which can lead to kidney failure. The main principles of lifestyle modification is to encourage healthy lifestyles for all individuals. The JNC7, or the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, recommends the following lifestyle modifications to reduce and control hypertension: weight reduction, the DASH eating plan, dietary sodium restriction or reduction, aerobic physical activity, and moderation of alcohol consumption. Let's talk about each of these lifestyle modification recommendations individually. Obesity and hypertension are intimately connected. Weight loss is the most important step in reducing hypertension and improving quality of life in the majority of patients. A loss of 1 to 2 pounds per week is generally considered safe or is recommended by a care provider. Weight reduction and maintenance of a normal BMI will reduce systolic blood pressure by an average of 5 to 20 millimeters of mercury per 10 kilograms lost. The DASH eating plan, or the Dietary Approaches to Stop Hypertension Diet, is a flexible and balanced eating plan that helps create a heart-healthy eating style for people with a focus on fruit, veggies, low-fat dairy, and whole grains. People who follow the DASH diet may reduce their systolic blood pressure by 8 to 14 millimeters of mercury. Let's talk a little bit about the DASH eating plan so that when you're talking to your patients about the DASH eating plan, you can keep this in mind. Let's look at the serving sizes of the foods they recommend. For grains, they recommend 6 to 8 servings per day, but a serving is 1 ounce of dry cereal or 1 slice of bread. I never really realized that a slice of bread, I always thought that 2 slices of bread, because that equals 1 sandwich, but really it's 1 slice of bread is a serving. And down here, when we look at lean meats and poultry and fish, they recommend 6 or less servings per day, but they are suggesting a serving is 1 ounce of cooked meat, poultry, or fish. Historically, we were taught that a serving is 4 ounces, but according to the DASH eating plan, 4 ounces would equal 4 servings. So keep that in mind when teaching your patients about the DASH eating plan. On average, American adults eat more than 3,300 milligrams of sodium per day, which is more than double the recommended limit for most adults. By reducing sodium intake to 2,400 milligrams per day or less, the average reduction in systolic blood pressure is 2 to 8 millimeters of mercury. Now look at this. This beautiful, ripe, juicy tomato is 6 milligrams of sodium. But once you put it into this can, even the no salt added, there's 20 milligrams of sodium per serving. This is the no salt added can. But once we process it as is regularly processed, there are 220 milligrams of sodium per serving. I think this is an amazing teaching tool for our patients to really get them to understand that when the tomato goes from a perfectly beautiful tomato, it's salt that gets it into that can. Aerobic physical activity is another very important, plays an important role in hypertension reduction. Any physical activity that increases your heart and breathing rate is considered aerobic activity. Blood pressure is reduced for up to 22 hours after exercise, with the greatest decreases among those with the highest baseline blood pressure. The Department of Health and Human Services recommends getting at least 150 minutes of moderate aerobic activity, or 75 minutes of vigorous aerobic activity per week, or a combination of moderate and vigorous activity. With moderate aerobic activity being that you are able to talk, but it is difficult to carry on a conversation, and vigorous activity being that you are able to say a few words, but unable to carry on a conversation. We should aim for at least 30 minutes of aerobic activity most days of the week. Regular aerobic physical activity can reduce systolic blood pressure by 4 to 9 millimeters of mercury. A cause and effect relationship between regular alcohol consumption and elevated blood pressure was first suggested in 1915. Recent studies have shown that the increase in blood pressure in heavy drinkers, equal to or greater than 3 drinks per day, averages about 5 to 10 millimeters of mercury, with systolic increases almost always greater than diastolic. Moderate alcohol intake for men is 2 drinks per day, and for women of any age is no more than 1 drink per day, with a drink meaning 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of 80 proof distilled spirit, which would be your vodkas, rums, gins, things like that. Reducing alcohol consumption can reduce systolic blood pressure by 2 to 4 millimeters of mercury. Tobacco really is the stinky elephant in the room of hypertension. Not only does smoking or chewing tobacco immediately raise blood pressure temporarily, but the chemicals in tobacco damage the lining of the walls of the artery. This causes narrowing of the arteries, increasing the blood pressure. Secondhand smoke also increases blood pressure. High adherence to antihypertensive medication is associated with higher odds of blood pressure control, whereas non-adherence to cardioprotective medications increases a patient's risk from 50 to 80%. So let's talk about medication adherence for a little. These are some statistics about how patients fill their prescriptions. For every 100 prescriptions that are written, 50 to 70% are taken to a pharmacy. 48 to 66% are picked up from the pharmacy. 25 to 30% are actually taken as prescribed, and 15 to 20% are refilled as prescribed. So what can we all do to increase the medication adherence in our patients? We can use this simple strategy. We will encourage patients to use adherence tools like day-of-the-week pill boxes or mobile apps. We will provide websites for additional reading and information. We will talk to patients to understand and address their concerns or fears. We will allow patients to speak freely. We will ask patients specific questions about attitudes, beliefs, and cultural norms related to taking medication, such as, how do you feel? Or what do you think? And we will ask patients simply and directly if they are sticking to their drug regimen. For example, how many times did you miss your medications this week? Self-monitored blood pressure is an evidence-based strategy that has been shown to increase control of blood pressure. Self-monitored blood pressure, or SMBP, technically refers to the regular measurement of a patient's own blood pressure. SMBP more broadly refers to the regular use of a personal blood pressure measurement device that is used by the patient outside of the clinical setting. The Agency for Healthcare Research and Quality, or AHRQ, found strong evidence that self-monitored blood pressure plus additional support was more effective than usual care in lowering blood pressure among patients with hypertension. The AHRQ found that 3 sessions of additional support within 6 months was the minimum to impact health behavior. So what does additional support look like? One-on-one counseling would include initial enrollment in the SMBP program and teaching the use of the home blood pressure monitor. Web-based or telephonic support relates to ongoing health coaching sessions done over the phone or over the web. And educational classes are often offered in the community setting and include classes at the YMCA, community centers, or others as appropriate. The self-monitored blood pressure feedback loop starts with the patient who is monitoring their blood pressure at home, taking their medications as prescribed, and implementing the lifestyle changes that we have taught them. The health coach is another important member of this loop. The health coach uses motivational interviewing to help the patient change their behavior. The healthcare provider reviews and evaluates the patient's SMBP readings and manages the patient's medication regimen. The last person in the feedback loop is the RN case manager, who coordinates between the patient, health coach, and provider to achieve optimal outcomes. So what are the recommendations for self-monitored blood pressure? How often does a patient have to monitor their blood pressure? 6 times per day. I know what you're thinking. What? It's 3 successive readings, 1 minute apart, in the morning and in the evening. But how many times per week? Every day. For how long? Until the patient's healthcare provider determines that the number of readings can be reduced. The proper technique for self-monitored blood pressure readings is to rest 5 minutes before taking your blood pressure. That means no talking, reading, or television. We should encourage our patients to avoid bathing, drinking alcohol or caffeine, smoking, exercising, and eating for 30 minutes prior to taking a measurement. We will sit in a chair with our back supported, feet flat on the floor with our legs uncrossed. Wrap the cuff snugly around the bare arm, lower edge of the cuff 1 inch above the elbow crease. Support the arm on a table or pillow with the middle cuff level with the middle of the breastbone. Measure blood pressure 3 times, 1 minute apart, and then record all results in the blood pressure log. The blood pressure cuff and monitor selected for the SMBP of BWise patients is the Ulm-Rhone model BP785N. Let's discuss how to set up and use this monitor. This is a picture of what the monitor looks like. To prepare the monitor, we will insert 4 AA batteries and replace the battery cover. Plug in the AC adapter. It is recommended that you install the batteries even if the AC adapter is used. Select your user ID. It doesn't matter which it is. The settings and memory will be maintained for both 1 and 2 separately. Set the true read mode and change the true read interval to 60 seconds. This means that the monitor will inflate, take a measurement, and deflate 3 times, separated by a short interval between each measurement. The true read mode is set to off by default. Once true read is selected, it will become the default. To use the device, we're going to remove tight-fitting clothing or rolled up sleeve from the left arm. Now let's talk about the left arm for 1 second. The recommendation is that you take your blood pressure on the arm that consistently reads the higher blood pressure, since they will both be different. The left arm should be higher than the right. However, in some patients, that is not the case. Additionally, some patients, if they have had a mastectomy or a resection of the lymph nodes in the left arm, it is contraindicated to monitor a blood pressure on the left arm. If either of those are the case, take the blood pressure on the right arm. Additionally, if the patient has had a stroke, you do not want to take the blood pressure on the affected site of the stroke. So, for the purpose of this discussion, we'll say take the blood pressure on the left arm, but use your best clinical judgment in choosing the arm that you will use your blood pressure cuff for your patient. As a note, do not place the arm cuff over thick clothes. To use the device, insert L, the air plug, into A, the air jack, securely. Apply the cuff to your left upper arm and secure snugly closed with the fabric fastener. Select your user ID and press the Start button. The arm cuff starts to inflate automatically and will take 3 measurements in a row. You will not need to press Start again. After using the device, record average blood pressure in the log and store the monitor. Let's talk briefly about the BWise self-monitored blood pressure, health coaching, and LSP pilot. We are anticipating that it will begin in October of 2016. Patients with a systolic blood pressure equal to or greater than 60 or a diastolic blood pressure equal to or greater than 100 will be eligible to be enrolled in the project. The patient is enrolled in the project with a referral in the same way that you would make a referral to a clinic. The patient needs to sign the BWise Home Blood Pressure Monitoring Agreement, and then she will receive a blood pressure monitor, education on the proper use of the monitor, a blood pressure tracker, a pill box, and any related incentives. The monitor and incentives will be provided by the local health departments and in Salt Lake County by the health coaches. Additional health coaching will be provided by BWise Clinical Service Coordinator. Additional information about this pilot project will be coming out to you shortly with a list of all needed resources. Keep an eye out for it. So, to recap, we have discussed the anatomy and physiology of the normal heart and the pathophysiology of hypertension. We contrasted primary and secondary hypertension and outlined risk factors for both types. We discussed the JNC7 definitions of hypertension and described the effects of uncontrolled hypertension on the various body organs and systems. We outlined the lifestyle modification recommendations to control hypertension and discussed the roles of our partners in patient care. We defined self-monitored blood pressure and described its benefits. We also demonstrated how to use the blood pressure monitor. And lastly, we briefly outlined the BeWise SMBP pilot project. If there are any questions after this presentation, please don't hesitate to call me at 801-538-6437. In addition, I will see if we can find the video for the heart video and attach it to the end of this webinar. This is a list of my works that I cited throughout this presentation. Again, if you have any questions, please don't hesitate to call me. Thank you very much for your time and attention.